I'm Deborah Gentile. I'm the Director of Allergy Asthma Research at Allegheny Health Network. And I spend about half my time taking care of patients, both children and adults, with allergy and asthma. And then the other half I spend doing research. Over the last few years, I've gotten very involved in the environmental impact of triggers on school children who have asthma. And what I'm going to walk you through today is some of our work that's focusing on the impact of air quality on asthma outcomes in our region's children. This is the first year of our work, and we're just getting ready to finish up the third year of work, and we'll have a much more robust sample size and data set to show you next year. We're going to be finishing our final school in the next month or so, and then hopefully everything will be analyzed in the fall. But what I'm showing you is the work from our pilot year where we got the model developed and up and running. Just a few asthma facts. Asthma is a chronic inflammatory disease of the airways. It affects 334 million people globally. And in the US alone, it affects 29 million adults and 9.3 million children. It's associated with significant morbidity, lots of ER visits, acute visits to physicians, healthcare costs related to hospitalizations. Many of these people who aren't controlled on good medications are really suffering and impacting upon their life. And unfortunately, even in this day and age with very good specialists and very good medication to control the disease, we still see about 3,500 fatalities each year in the US alone due to asthma. And that's very sad because most of these deaths could be prevented. Huge economic impact. The annual direct healthcare costs are about $1.7 billion. They're expected to almost double across the next few years. And most of the cost of this is related to emergency room visits as well as hospitalizations. And again, if we could learn what's triggering these patients and relieve the triggers and also get the patients on appropriate controllers, we would really improve morbidity, mortality, and drive down these costs. I'm not showing you this, but it'll come out more on the next slide. There's also indirect cost. Children miss school, adults miss work. It's a huge economic burden many times for families. The final thing that's going to come out in this talk is that asthma is really a disease of disparities. In pediatric asthma, we tend to see more males affected than females. Across all different ages of asthma, we see racial and ethnic disparities. And a lot of that's related to where these patients reside. Many of them are residing in the inner city and exposed to a variety of environmental factors, including but not limited to outdoor air pollution. And then there's disparities with age. The very young are vulnerable as well as the very old. Now, as a pediatrician, I'm very concerned about health implications on a child's learning, and it's very well established that asthma affects school performance and attendance. Asthma is one of the top chronic causes of absenteeism. There's about 13 million total missed school days per year in the US alone due to asthma. And each child with asthma spends about 8 million days a year in bed due to their asthma. This can have a profound impact on their ability to learn because they're absent, or if they're there, they may not have slept well the night before because of their asthma and they can't pay attention, or they're having trouble breathing right there in the classroom and can't pay attention. A lot of these children don't participate in activities because their asthma is not controlled. They think it's very normal to be sitting on a bench and not going out at recess, and that's totally against what we want to see. We also have, interactions between obesity and asthma, and if these kids are sitting on a bench and not getting physical exercise, that interaction is going to be manifested even higher. So our goal is to really get them active. A lot of these kids don't socialize with the other kids. They often end up, particularly the moderate and severe asthmatics, because they're missing school. They're missing a lot of after school functions. They're getting behind in schoolwork. They're just struggling. And as part of that struggle, they're really not interacting with the other kids as well. Not only is this going to impact upon them in school, but if they're not able to attend school and keep up with the other kids, this could potentially impact upon what happens to them later in life with what career options are available to them and whether they're even going to qualify for higher education. So I think it really has some potential downstream impacts in the lives of these patients. Huge regional impact of asthma. Just as it is in some other cities, asthma is a major public health concern. The 2015 Allergy and Asthma Foundation of America, they ranked Pittsburgh as the 27th most challenging city to live with asthma, and there's a variety of reasons for that. We have a high rate of asthma prevalence, high rate of poor control, and we actually have high levels of environmental exposures. And the exposures that are quoted in this report include pollens as well as air quality. There's other exposures as well, but we seem to be, improving somewhat with the tobacco smoke. And they also talk about the disparities again. We'll talk about socioeconomic disparities as well as racial disparities. Recently, the American Lung Association released their list of the most polluted cities in the U.S., and Pittsburgh ranks currently 8th most polluted city based on annual particulate matter, PM 2.5 levels. So you can see we have a ways to go with a variety of these factors. We need to improve our ranking with how we're taking care of patients with asthma, and that includes decreasing trigger exposures. And you can see that one of the triggers that we're still having an issue with is some of the air quality. Again, as the previous speaker said, we are improving and we continue to improve, but we want to make you aware throughout this presentation that we still do see, issues with the air quality. It can still get better, and we still see some disease effects caused by it. Now, there's a lot of different factors that can influence health and outcomes. Some of it's in your genes, what you inherited from your parents, and then some of it's related to environmental factors. Some of it's also related to behaviors of patients. I'm not going to spend time going through all this, but these things can really interact significantly. Education plays a big role as well, gender, social environments, in addition to those exposures that we're going to talk about. The environment can have a huge impact upon childhood asthma. And again, we don't think asthma is just caused by air pollution. We know it's caused by other things in the environment, and I'm listing them here. We know certain infections, particularly in early childhood, are linked to the development of asthma. We know indoor exposure to tobacco smoke is linked to the development of asthma as well as a trigger. Outdoor pollution, including industrial sources, the point sources that were talked about earlier, residential wood smoke, and mobile sources, they all contribute to asthma. There's a lot of emerging research that shows some dietary factors and lifestyle factors may play a role as well. And there's a lot of really interesting work being done with these patients who live in the inner city, looking at interactions between violence and stress and their exposure to these type of things and how it impacts upon their asthma. And some of that can be a direct effect of their psychological stress. Some of it's also related to the fact that if they live in violent areas, they're often kept in the house and not getting outside to exercise appropriately. And the last thing I want to point out is that over the last several years, many of the investigators have been starting to look at interactions between these factors. And I'll mention that again later in my talk. What we think happens is that some of these factors can combine and the disease can be amplified. So that's an important consideration. Just briefly, there's a lot of adverse health effects of air pollution. You heard about some of these already. I borrowed this from the 2016 ALA State of the Air report. The health risk factors from air pollution are due to ozone as well as particulate matter, and then many of the other chemicals that were mentioned earlier. And it can affect both children and adults. Again, it can affect their heart, it can affect their lungs. We heard earlier about how it can affect cancer risk as well as mortality risk, and even impacts on learning and autism directly. So there's a lot of things that can be impacted by exposure to outdoor air pollution. I know my next speaker, Dr. The next speaker is actually going to spend a lot of time talking about the link between effects of air pollution and asthma. That will be Dr. Brower, but I just wanted to summarize it. This is very well known and established that air pollution can cause increased bronchial hyperresponsiveness, and bronchioles are the airways in your lungs, and if they're hyperresponsive, that means they respond to stimuli much easier than if they weren't responsive. Increased airway inflammation or swelling, which is the hallmark of asthma. We often see decreased lung function or spirometry results in these patients. And it's very well established that these patients have increased hospital admissions and ER visits. There's also enhanced airway inflammation that's induced by allergen exposure. And again, that goes back to some of these factors working together to cause issues. There's also priming or making the airway more susceptible to allergy exposures. High exposure of air pollution is an independent risk factor for wheezing during early infancy and childhood. Again, all these impacts of air pollution on asthma in childhood are very well established. We know there's an issue. I'm going to spend a little bit of time talking about how we define asthma prevalence before I move into my data. The definition of asthma prevalence is the proportion of a population that's affected by asthma at a point in time. So the results are only valid for the population under study. We come up with this number to help us answer questions about how many people actually have asthma at a specific point in time, and it also gives us a lot of information on the magnitude of the stated disease burden in the population. The Centers for Disease Control uses two different measures, and we're going to show you some of these across the nation, the state, and our county. They look at lifetime prevalence, that means have you ever had asthma? And they also look at current asthma prevalence, do you currently have asthma? And I just want to define these up front so everyone understands. And again, when I go through my data, my prevalence is only specific to the population I studied. And I want to make that very clear up front. Our data yet isn't generalizable, but I'm going to show you some of the generalizable data collected across the country and state. Here is a state and county methodology I'm going to show you. They utilize what many states do, behavioral risk factor surveillance system. It's the world's largest phone survey that collects U.S. health-related data. The Pennsylvania component of it is a state-based system of health surveys, and they actually do a unique callback survey. If someone identifies as having asthma, they'll give them a call back. There are limitations to this data as well. All data has limitations. This data is self-reported. These are random phone calls made in an area, typically the counties and across the state. They're subjected to response and recall bias. Do patients remember what's going on? Are they responding, appropriately? Did they understand the question? Also, there's no representation of those who do not have phones. Prior to 2011, they were only calling landlines, and we know many people now don't have landlines. They use cell phones exclusively. So since 2011, they have been randomly calling cell lines as well as phone lines. But there's no way to get representation of those without phones. Also, the number of respondents are declining as time goes on, and I think that makes sense. My cell phone rings. If I don't know the number, I don't answer it. So this may not be the best way to collect the data in years to come. And they're already starting to see that the numbers of respondents are declining, and they're worried a bit about the reliability of the data as years go on if we don't reverse that decline. But again, this is the best we have. It's a good system, but there's always flaws with everything. So you have to understand that as we go forward. This is showing the 2013 pediatric self-reported asthma prevalence rates that were reported in the Pennsylvania Asthma Prevalence Report in 2015. These are the most updated numbers available. In pediatric patients, those less than 18 years of age, the U.S. prevalence of asthma is 9.4%. In our state, it's 10%, and within our county, it's 14%. So you can see this, and you can expect it from some of the earlier talks that because of the concentration of the population near point sources of pollution, you may expect it to be a bit higher. Now I want to go on and tell you how I got involved in this area. We have a lack of objective regional data. I, in clinic, see many patients from the inner city who have asthma. I interact out in the community with a lot of school administrators and school nurses. And I've had nurses in public schools tell me half the children have inhalers. And that's very hard to believe that half the children would have asthma. So we started to look into this a bit. And it's very important to know that that data I just showed you about national, state, and even county asthma surveillance data, it can't be extrapolated down to those local areas. The sample size is such so that it's good at the county level, but once you start looking at neighborhoods, you don't have enough patients in each neighborhood that you're looking at. There just aren't adequate local sample sizes. Again, we've had data given to us by the Pennsylvania school nurses, but it's typically not mandated how they report it. Some of the nurses report it as who has a history of asthma, as the mom tells them or the dad. Others report it as someone being, given an asthma inhaler to use in school. And there's no evidence of any type of formal evaluation in many cases. So the bottom line there is even within our county, the nurses can report it differently. There's no standard method, and that certainly applies across the state as well. A few years back when we started to get involved in this work, Northgate School District, which is downwind of one of the point pollution sources and it recently closed, they were actually getting hammered a lot in the media for having very high asthma prevalences. At one point in the earlier years, they were reporting them in the 30s, and in more recent years down to about 20%, which is still higher than you would expect for our county level. And again, I've had some school nurses tell me about half the kids in their school do have inhalers. So whether they truly have asthma or not, we don't know. Typically what the nurses are reporting in my geographic area is who has an inhaler. But again, in some areas, they may be reporting more historical diagnosis. Again, typically don't have objective data. So we really wanted to get to the bottom of this and try to find out, are there pockets of asthma among some of these different school districts, and can we relate it to different environmental factors? So with funding from the BREATHE project of the Heinz Endowments, we started a pilot project several years ago, and that project has now expanded to full mode. And again, those results for the full mode project will be available in the fall. We entitled this Surveillance and Tracking of Asthma in Our Region's School Children, or STARS for short. We decided the first step in really improving these public health outcomes is to clearly identify the prevalence of asthma. Do some of these kids, do they really have a 50% prevalence? That's hard to believe. We want to find out if that's true. And the first step is to really initiate accurate and efficient methods to conduct asthma surveillance and tracking. The best way to prove if someone has asthma is to do a challenge on them, but that involves going to a medical center and spending a lot of time on it. There's no way that can be done on widespread populations. You'll see we developed a validated survey that's used by the Breathmobile Project in LA and several other cities. And then we did tag upon it some of our objective measurements of lung function and lung inflammation. And in the future steps, again, this is a pilot study that we designed. We wanted to start to explore these things, but weren't necessarily expecting to find outcomes yet. We wanted to start to set up the model to explore environmental triggers and then potentially implement intervention and influence policy with our results. This is the project design for the pilot study. Again, the objective is to develop a model to effectively and efficiently identify school children at risk for asthma, and we typically use this asthma detection survey among other things. The survey consists of 4 questions, and this has been used for quite a few years in different cities, including Los Angeles, and Baltimore also does this as well. Many of the cities that are using it are affiliated with the Breathmobile program. Ask 4 simple questions. Is there a prior diagnosis of asthma? Again, that can be subject to recall bias. It's self-reported. Has the child had repeated episodes in the past year, looking to see if they're currently active? How often are they symptomatic during play or exercise? That gives us an idea of their severity level and their control level. And how often have they had symptoms in the past? Now, these aren't exactly how the questions are asked. I simplified them a bit for the presentation. But this algorithm there's an algorithm then developed to, depending on how the patient scores these, and they're scored on a scale of 0 up through 4. Depending on how they score these, we feed them into a computer algorithm, and it actually can tell us if they're at risk of having asthma or not. It basically has a sensitivity of about 86% of identifying at risk of asthma and a specificity of about 84%. That's pretty good for a survey. It also has about a 91% sensitivity of identifying persistent asthma. So that's very good as well. As an overview of the research project, we were hoping to recruit in that initial year 150 fifth graders from regional elementary schools. I picked fifth graders because I thought they would be the easiest group to work with to get the model up and running. I didn't want to get high school kids because if we do follow-up in 5 or 10 years, they may not be available. I tried to stay away from the little people, the kindergarten and first and second graders, because we were doing spirometry and lung function testing and another breathing test to measure airway inflammation, and we were worried that we wouldn't be able to collect good data in them. So we wanted to go with a group that we thought could give us good results in the pilot, to help us work out the kinks. We also used a demographic survey, which gave us, their home address, and also we asked about insurance status, whether it was public or private, and got, an idea of their socioeconomic status with that. And then the asthma detection survey. This is how I define prevalence in this study population. Again, the prevalence I'm going to show you is specific for my study population, and it may not be perfect. Just that we saw that the state and county numbers aren't perfect. The prevalence here is looking at the risk of asthma, both physician diagnosed and those that we're newly identifying as having potential risks for asthma. And again, the survey is pretty good. If we think you're at risk for asthma and do further studies on you, about over 80% of them will end up being positive for asthma. We're also looking at the prevalence of uncontrolled asthma and those with known physician-diagnosed asthma. So those results are very robust because it's the cohort of kids who come in already knowing they have asthma, and then we're going to look at what their disease control is and then the different environmental factors influencing it. There are limitations, just like there were limitations to the study I showed you earlier. This was our pilot, school self-selected, and I'm going to be honest with you. We did a press release on the award coming and the study that we were going to do, and I had schools very near point sources of pollution. I had their administrators calling me in a matter of days wanting to participate. So there is some bias there with the school selection. Also, the patients could participate or not participate. We learned a lot about how to get them to participate. When we first started at the first school, we only had about 30% participation. By the end, we were up to 70 to 80%. A lot of it's just building relationships with the school as well as the community, and it's not something that happens overnight. Our statistician wants us to have about a 70% participation rate. Overall, when you combine everyone from this first pilot year, we were at about 50%. So there's room for improvement there. But we've incorporated everything we learned into this next 2 years that we'll be showing you in the fall. And again, this is just the prevalence in my specific study population. It's not necessarily generalizable at this time. I think once we get up to the 70% participation and we have more schools participating, as we are doing right now, we'll actually have more results that are generalizable. Also, this study was pilot in nature. It was designed to explore associations with environmental factors. It's not set up to prove one thing or another. It's just really to start to look and to see where we need to concentrate in the future. And also, looking at these factors requires us to get models up and running. One of the things we looked at was outdoor air pollution using the mobile sampling platform and stationary reference site that Albert Presto at CMU has developed. And you heard a bit about his work earlier. And Albert's been very key with helping us get this work done and getting the study results to us. We also looked at tobacco smoke exposure in these children. We actually, when we see them, have them chew on a cotton ball and spin it down and get their saliva and go back and measure cotinine, which is a metabolite of nicotine. And there are assays that you can do in the lab, and you can measure how much cotinine or nicotine exposure is in there. And there are cutoffs that establish whether they do have secondhand smoke exposure or not. We can also look at psychological stress. I'm not going to spend a lot of time on that today, but there's a lot of work being done in inner cities looking at the impact of stress on asthma in these patients. That same saliva that we collected, we can also take it and put it in another kit and look at their morning cortisol level. We're also looking at obesity. It's very much tied to asthma, and we're collecting their BMI information there with the height and weight. So basically, we send a consent form home, the parent returns that with the survey, and then we run the kids through a little line. It takes about 10 minutes max, where we come in, verify that they've been consented to proceed. We get their height and weight, we get their little salivary cone, their saliva sample, and then they go right back to the classroom. So it's very efficient, it's not disruptive to the classroom. We actually have our coordinator of the program go into the classrooms ahead of time and give them a little lecture on breathing and lungs and asthma, so they understand what's happening. And that takes about 20 minutes, and it's typically either facilitated in a health class or in a gym class. So they're learning something as well. And again, it hasn't been disruptive in any of the schools with the learning environment. Also, we're looking at socioeconomic status, and that's public versus private health insurance. So the first year, again, we planned to enroll 150, but we had a pretty vigorous response. We had 267 fifth graders who participated. They were from six different school districts. Again, many of these are near point sources of pollution. Northgate, Allegheny Valley, Gateway, Woodland Hills, the Environmental Charter School on the east end of the city, and Waldorf School. Overall, when we first started, we only had about 30% participating, learned lots of tricks, got up to 70 to 80, but what I'm going to show you, the overall participation rate was 50%. Equally distributed between males and females, a high rate of African Americans, about 37.5%, and then a high rate with public insurance indicating, lower socioeconomic status, 44.2%. This is showing the prevalence of asthma risk in the study population. And again, it's in the study population as to 50% of the fifth graders who participated. Overall, the rate was 40%. Those who had a previous diagnosis, it was 28.7%. And we identified approximately 12% to potentially have asthma. They're at risk for it. So if you follow the algorithm, about 85% of that 12% will most likely have asthma with further evaluation. And we actually do refer these patients back to their primary care doctor. We give them a report so they can follow up with them. So those numbers are pretty striking. I think even if you would make an assumption that the half that didn't participate didn't have asthma, those numbers are still pretty striking. And it's concerning to me that this is going on in this day and age, and we're in a city with excellent healthcare providers, and we have excellent controller medications, but these kids are still having problems. We did an analysis, and again, this is pilot work. We were working, with Albert with the air pollution. We got the BMIs. We had some tobacco smoke exposure results. We wanted to start to explore what the environmental factors were that were influencing asthma risk. And what we're looking at here, the first line is really if patients who had an elevated BMI, they were 3.3 times more likely to have a risk of asthma. Also, those who were exposed to the higher than the median level of the particulate matter in the study, they actually had a 3.2 times higher rate of asthma. And you can see that that level that we're measuring, that Albert measures, is within acceptable limits. And the whole range was within acceptable limits, but when you start to partition it by quartiles and in half, children who are exposed to higher levels of even within normal limits particulates, or acceptable, I should say, they still have, some association of being exposed to pollution and an increased prevalence of asthma. I think the point, and I'm going to make this on a later slide, is even when the EPA sets these guidelines, there's a lot of data that it shows even if you're in an acceptable level below their threshold they set, there can still be associations with disease. And that's very well known. And that's why we want to keep striving to improve the air quality. Even when we achieve attainment, we want to keep going lower and lower and as low as we can. As far as the asthma risk, tobacco smoke, if they were exposed to tobacco smoke, they had about a double risk of having asthma. Now we're going to look at the prevalence of asthma. Wrong way. We're going to look at the prevalence of uncontrolled asthma. Now these kids that we're looking at here, I only analyzed the ones who came in and said they had physician-defined asthma. So that 12 or 13% that were at risk but not yet defined, I didn't include them in this because I wanted to make it as pure as I could. So a little over half, about 55% of the kids who we knew had asthma were well controlled, but 45% aren't. And those are the kids who are not sleeping at night because of asthma attacks. These are the kids who are missing school. And then these are the kids who, just aren't participating in activities. And this is really unfortunate because there are many good asthma specialists here in Pittsburgh. There's many good primary care physicians. And we have no cure for asthma, but we have very good medicines, both inhaled and oral medicines for control that patients can take as little as once a day to help them gain control of their disease and live a normal life. So that number is alarming, and it's something we need to address, really. Again, we did do the pilot work looking at the environmental factors here and what was influencing the uncontrolled disease in patients that had physician-diagnosed asthma. Again, this is from Albert's measurement work. The children who were exposed to higher levels of black carbon, we cut the range in half. Those who were exposed to higher than the median black carbon level actually had a 6-fold increase in the prevalence of asthma. This next one is very interesting. Tobacco smoke actually increased your risk of having asthma, but when you start to break it down about who's uncontrolled, it's really not playing a role. The poorer children who had public insurance but no tobacco smoke exposure actually had a 6-fold increase in their risk of asthma. And we do know that we are making some headway with decreasing the rate of tobacco smoke and really educating people to not smoke indoors and whatnot. But I found that quite interesting that it was the children, with the public insurance and lower socioeconomic status who didn't have tobacco smoke exposure, were still at a higher risk. So I think it's important to remember these are pilot results. We had enough data to analyze and get some reliable results, but we're going to have even more after we finish up the current project. And then these results will be more definitive at that point. I want to stop and summarize the work from STARS. In that study population, we had a high prevalence of asthma risk, physician-diagnosed asthma, as well as uncontrolled asthma in physician-diagnosed patients. There's an association between prevalence and specific environmental factors. And again, asthma is multifactorial, but we're talking about air pollution today, and air pollution did have an impact on those associations. Again, I have to stress this is a pilot study and it does have limitations that we went over, and fortunately the more definitive study is in progress. The whole purpose of this was to get up and running, get into the schools, get into the community, get the model working, so that the second year we could hit the ground with our feet running and really collect good data. In conclusion from that, childhood asthma in our region is potentially underdiagnosed and undertreated, and that's despite the availability of PCPs, asthma specialists, and controller meds. And again, there's multifactorial disease going on, but poor regional air quality is among one of the contributors, based on our pilot results. And I think it's an important one because it's one that, if it's fixed, it benefits all of society. And no one's choosing to live near these sites, I want to go move next to the power plant or whatever. They're living there because they're poor, and they really don't have a choice. What we need to do is really develop interventions as well as prevention programs. I'm going to talk a little bit about a few arguments that often come up when you talk about air pollution and asthma. And then I'm going to move into some of our newer work and trying to work with these kids in schools to improve their asthma control. The biggest argument you hear is, well, the air is much cleaner today than it was when all the steel mills were running, so how can the increase in asthma rate be due to poor air quality? And this is where that multifactorial issue comes into play. It's well documented that asthma is multifactorial, and there's interactions between different triggers that can amplify the likelihood of having asthma attacks. It's very well established that there's an interaction between respiratory viruses and tobacco smoke, and it's also very well established that there's a relationship between obesity and outdoor air pollution. And I think that's important because many of the patients do have obesity issues yet too. And what they're thinking is that the patients who have asthma and are obese, when they're breathing in the air pollution, it's getting concentrated in their fat cells, and it sticks in their system longer because there's more fat cells. They also postulate that there's some endocrine effects of the air pollutants on the endocrine system that will lead to obesity. So I think it's very important as we go through this, what we want to do with the larger cohort of STARS patients, which we are currently finishing up enrollment with. We're going to have a much larger sample size, and we're really going to start to look for interactions between those different triggers. Obviously, we're interested in looking at air pollution and obesity because other studies have shown interaction there. I'm also very interested in looking at interactions between air pollution and pollen levels. About 80% of children who have asthma also have allergies, and over time our pollen levels have just been climbing, and our seasons are longer and the levels are higher than they've ever been. And we actually think a lot of that is due to some of the global climate changes that we're experiencing. So those are things we're hoping to look at more definitively with the larger study. I want to bring this up. This is to point out that the air quality values I showed you in my study are all within acceptable EPA limits. But the point of this is to show you that we know even breathing air with those levels can be harmful in certain patients. The lower you can get it, the better off you are. This is a global study looking at air pollution and premature mortality. This is pretty much a landmark study that was published in Nature just last year. They used global atmospheric chemistry model to investigate the link between premature mortality and 7 different emission source categories in both global, urban, and rural environments. So they were looking worldwide. The summary of their results are really striking. 3.3 million deaths a year are attributed to fine particle pollution. They actually expect this number to double by 2050. They identified 3 top contributors: energy sources such as coal and biomass, agriculture, and traffic. And they go on to talk about the different countries and what was driving them and whatnot. They actually go on to state that the results suggest that in the U.S. and other advanced countries, I should say, with low ambient levels of pollution, we have lower levels in some of the other countries. There's still sizable public health benefits to be achieved by further reducing these emissions from fossil fuel power plants and traffic. They clearly show that even if you're below the EPA levels, you can still get better health outcomes if you keep trying to push that level down. And I think that ties nicely into my work. We're really not out of the containment range, but you can see a correlation starting to develop. This is another study I like to refer to quite heavily. This was done by one of my colleagues, his group, and what they looked at was improving air quality rapidly in patients who have asthma by moving them from a polluted area to a non-polluted area. What they did was they took 37 untreated children with mild persistent asthma. They recruited them from a highly polluted urban environment, and they actually relocated them for a week to a less polluted rural environment. 1 week after relocation, they did all types of objective measurements. They actually saw a 4-time decrease in nasal eosinophils, and eosinophils are cells that are in our airway passages that are associated with allergy and asthma. They also saw a significant decrease in exhaled nitric oxide, which is a measure of airway inflammation or swelling. and they actually saw significant improvements in their lung function after 1 week of being removed from the pollution sources. So that's quite remarkable. So when people tell me we really, air quality really isn't a big player, we know it's not the only player, but yes, there's a lot of data showing that it does cause problems, and if you can remove it, you can quickly, reverse some of these short-term outcomes. So I think it's a very important thing to keep focusing on. Now, when we were doing all this pilot work in the schools, we started to feel bad. We were finding these kids that had poorly controlled disease, and the study wasn't really designed to help them. I was just picking them out. So I teamed up with my colleague, Jen Elliott, who's a pharmacy doctor over at Duquesne and on faculty there, and we've worked together for quite some time in the community. And we developed an interdisciplinary mobile model of asthma care. It's basically trying to replicate the breath mobile that's been very popular in Medicine East for some time. We girls like acronyms, so we called this Caring for Asthma in our region's school children CARES. And basically what we do is we both go on the van periodically, and we'll show you how often we go. And we go, typically right now we're going to the Woodland Hills district, and we're going to start in the fall going to Clairton, because these people really have the need. They're right next to point sources. Many of them are underserved, socioeconomically disadvantaged. So what we do is we team up and we go in there. And the whole rationale for this was the STARS identified the need. We felt terrible not being able to provide care. And then the thing we found out when we were out in these schools, and you learn a lot by being on site, these children use their school nurse as an acute care center on Mondays. Many of these kids in the Woodland Hills School District don't live on a bus line, and they actually, if they have a minor injury or an illness over the weekend, they don't go get seen. They wait to see the school nurse on Monday. We've been in school nurses' offices first thing Monday morning. There's 20 or 25 kids waiting to see her. Their parents don't have transportation to get them where they need to be. So that became apparent to us as we were talking to both the administrators, the nurses, as well as the participants. So we thought this would be a good model to bring into them. Here's the overview. We hope to recruit 30 children this first year, and we again focused on those younger kids, because if we can make an impact, if we can collect data here and we do something to impact upon their rate in the future, we can go back and look at them. So we were looking at 6 to 12-year-olds from Woodland Hills School District. We took the van out from Duquesne at baseline, and then we came out again at 2, 4, 8, and 12 weeks later. The first part of the visit was me and my staff as the asthma specialist. We did asthma control test, how uncontrolled is their disease, how severe is their disease. They did asthma quality of life questionnaires, how's this disease affecting their school performance, sleep, and life in general. We did objective measurements of lung function testing with spirometry, as well as inflammation with exhaled nitric oxide. And then we also assessed severity and control. I did that, and then I made medication adjustments. And the beautiful thing about this is that Duquesne Pharmacy actually provided the medicines for these patients. We weren't having to worry about going through insurances and whatnot. They actually would either deliver the medications to the home or put it in the mail so they would get it the next day. So we were really stripping away the barriers. They had the doctor right there. They had immediate access to the pharmacist. And then the pharmacist, Jen, would actually spend time after my visit assessing their compliance with the medication, and she did knowledge testing about asthma, including how to use their meds, what's the controller, what's the rescue, do you know how to use these? So are they using them appropriately, and are they taking them? Those were our real outcomes in this first run. Last semester we enrolled 16 and they were completed, and right now this semester we're finishing up the last 14 and they should complete in the next week or so. The preliminary results, basically 100% compliance with visits. How can they not be compliant? We're right there. The nurse brings them to us during an activity period or recess, and we can see them. Typically it takes maybe 15 or 20 minutes. The first visit takes a bit longer. The parents can come to the visits. If they're not able to come, we contact them by phone, and that's worked out so far. We actually saw 70% compliance with medications after they started interacting with Jen and her team and learning how to use the meds and the importance of taking them. And that's important. In general practice, my patients are only about 50% compliant, so that's actually pretty good for a pilot study. And then we actually saw improved knowledge, significantly improved at about 2 weeks, and it even improved more so at the 4-week visit. And I think that's due to you reinforcing things. Hearing it once just isn't enough. They need to hear it a couple times in pretty quick succession. And that's what I do in my clinic. If I have a new asthmatic and I'm seeing them and giving them a diagnosis and meds, I want to bring them back in several weeks to teach them, to make sure they're doing things right. So overall, this model appears effective. We're hoping to expand this, and my institution is also working on plans to develop a multidisciplinary asthma clinic in the Woodland Hills School District, and hopefully we'll open up in the fall. What we'll do is visit there, once every week or every 2 weeks and repeat this type of thing, but offer it to all comers. These are our current directions. Right now we're continuing the CARES program, so we'll have those results available soon for all 30. We're finishing up the district-wide screens. The big players were Woodland Hills, Clairton, and Northgate. Again, near point sources of pollution. And then we're also going to be hitting Hazelwood before they dismiss for the summer. And we've hit some other schools in between, but these are the big players. Where do I want to see this go in the future? I'd like to see this expanded into a screening program. Just like the nurses screen for hearing and vision, I'd like them to include these 4 questions in their survey at the beginning of the year to try to find out who these kids are so that we can start to work with them in school. There's many groups that will come in and do education, not only for the child with asthma, but for the peers who don't have it so they understand the disease. These things can be incorporated easily into the health classroom or science. We want to start to develop these school-based programs that I talked about, the asthma clinic. I'd love to see some of the programs locally come in that are really trying to raise awareness about these triggers and teach children about triggers. Again, not just air pollution, but tobacco smoke. We'd like to see those once we have the clinic, these people coming in and out and working with the kids as well. And ultimately, you want to do primary prevention, and that means reducing, but it really means eliminating the environmental triggers. And again, this disease is multifactorial. Some of these triggers are hard to eliminate. There was a recent study published that showed that obese patients who were offered counseling and a program to lose weight in their workplace, only about 20% of those who were eligible took advantage of it. So it involves some patient motivation to do it. The air pollution issue doesn't involve patient motivation. It's something that we could, try to continue to improve, and then not only help asthma patients, but improve overall health outcomes in a variety of populations. So I think it's important to continue along that pathway. In conclusion, I just want to end by saying childhood asthma does remain a local issue. And I'm very much concerned about these kids, that almost 50% that have poor control. This is going to impact upon their learning. They're going to probably have difficulty getting into, vocational training, technical training, or college because of their, missing school and having bad grades. And it's really going to impact upon our region's sustainability in the future if we don't address it. We need to have a healthy population that's able to, be educated and go to work and produce and help the whole region. So this is a huge issue. And this is true of all chronic diseases, not just asthma. And again, there's multiple factors associated with the asthma outcomes. One of the lower hanging fruit is really the cleaning up of the air. Again, we're doing a great job. The levels are coming down, but we still have some ways to go. And I gave you a flavor for even in studies where there's normal levels reported, is still a curve that the higher level in that normal range of pollution still associated with some health outcomes, adverse health outcomes. So we'd really like to see cleaner air achieved like it's been in other cities that you just heard from Norm, and that will globally benefit all the residents without anyone having to undergo motivational changes, for their lifestyle. Those things are very important, and we want to continue to stress them. But again, this is low-hanging fruit that we should be able to address. It's been addressed elsewhere. So I'm going to go ahead and end there. Thank you.